Awesome. Good morning, everybody. Excited to be here to talk about this overdose prevention, harm reduction. And thank you. Just wanted to also say thank you to Lexi Perry for joining us today. We had the privilege of working together at Maine General before we both went on to other projects, but was just a really important leader at Maine General around harm reduction with our syringe exchanges. When I was putting this lecture together, it was actually kind of exciting and fun because it's kind of a slightly different than maybe what I usually lecture on. But I think as the disease process and the severity of the disease process has really changed in terms of the pregnant women that we're taking care of being so sick. In some ways, I think I've probably shifted in many ways more to a harm reduction model than I ever had before, just in an attempt to keep those high-risk folks engaged and getting the services that they need. So next slide, please. So harm reduction, I really liked this. I was trying to find a perfect quote to describe this, but substance use during pregnancy doesn't exist in isolation. It's often combined with a multitude of other adverse circumstances, including poverty, interpersonal violence, psychiatric comorbidity, polysubstance use, nutritional deficiencies, inadequate healthcare, and stressful life experiences. So that captures it, right? So we're seeing patients not just for their substance use disorder, but for the whole, all the services that they need and all the issues that they're dealing with. And I also really like this picture that I think if, at some very basic level, harm reduction means treating folks with respect, dignity, and compassion. So really meeting people where they're at, which can change over time. Next slide, please. Oh, I have no objectives or disclosures. Or sorry, the objectives are there. I have no disclosures. Sorry. So what is harm reduction? I mean, I think this is one of these big challenges within the field of substance use disorder because harm reduction is accepted in so many other settings. So you think about it like seatbelts, that's straightforward. You know, having a smoke detector in your home, bike helmet, sunscreen, these are all things that are harm reduction. So why is it so hard to accept for those with substance use disorder? And this is really where I run into constant sort of pushback, particularly when I'm talking about syringe exchanges. And I think it really boils down to most people feel that harm reduction to some extent is enabling or encouraging use. It keeps people addicted. I've heard that many times. And I think there's a lack of understanding in that. I think the perception of harm reduction is that we're getting people to necessarily reduce their use, which is not necessarily what's happening. That harm reduction really is the approach that helps to reduce the negative effects of the substances that a person might be using or continuing to use during that pregnancy. So syringe exchange, great example, right? You're going to reduce the risks of infectious diseases that patients can acquire if they are using needles to do drugs. So it's all about sort of reducing the negative effects of ongoing substance use, not necessarily reducing the substance use itself. I mean, great if that happens, but that's not necessarily the overreaching goal. So I think another really important point, which I've sort of already made, is that harm reduction ensures that women with substance use disorders are being treated with kindness and respect. So I just want that to sort of overlay the entire conversation. Harm reduction is about meeting people where they are. You know, how can we best help you stay safe, healthy, and alive? And I think when I'm working with my most complex patients and my most at-risk patients, sometimes I literally am saying, how do I support you in staying alive this week? Because sometimes it really is about getting to that 7th day, right? It's not about, you know, you can't even look at the global situation a year out, 2 years out. You're just, how do I help you stay alive in the next week? Next slide, please. So why harm reduction? It increases engagement, retention in prenatal services and SUD treatment. It increases referrals to other health and social services agencies and increases that engagement following birth. Again, it's just maintaining a connection with patients who, you know, 5-10 years ago might have been discharged from a program, right? I mean, this is about maintaining that connection, helping them get the resources that they need to improve some aspect of their well-being. It does reduce alcohol and drug use because, again, it's sometimes as you're working with people and connecting them with resources, they're more able to sort of cut back on the use, but that itself is not the goal. It also improves nutrition. It substantially reduces healthcare costs by improving outcomes. So that's not surprising, right? So if we're seeing people in treatment, we're connecting them to resources, we see fewer maternal complications, lower rates of preterm and low birth weight infants. It also increases the number of infants that are discharged home with their mothers following birth, which enhances the likelihood of, you know, developing healthy attachments, et cetera. Next slide, please. So risk of overdose during pregnancy and postpartum, I pulled this quote because I thought it very well captured the postpartum period. So sleep deprivation, dramatic hormonal shifts, and the day-to-day realities of caring for an infant create enormous stress for all women, but especially for those who are struggling to stay in recovery from drug use. So just, thinking about all the challenges that those of you who are mothers out there, I still remember that sort of 2 to 3 months, coming home with a new infant, total sleep deprivation, stress, husband traveling for work. But I had resources, I had family members, I had a shelter, I had food, I had all those things in place, and I wasn't dealing with a substance use disorder. So adding all those issues on top to an already stressful situation can be very difficult. Drug-related deaths and mental health crises or suicides are some of the leading causes of death postpartum. I was pretty surprised to read that. So particularly if you lump those two deaths together, and oftentimes it's hard to distinguish the two, they are actually the leading cause of death if you put those together. The overall overdose rate among women in the year before and after delivery is about 8 per 100,000. So we see actually the lowest number of overdoses in that third trimester, and then the highest number of overdoses 7 to 12 months after delivery. So I think I really try to keep in mind that period is particularly risky, even though it's not the immediate postpartum period, which you sometimes think it might be. But I think sometimes that's when some of the connection to care, the connection to resources, the connections to support really fall off. So important to know that that's the highest risk time. Women most at risk of overdose have infants with a diagnosis of neonatal abstinence syndrome. That doesn't mean much to me because I think a lot of that's about how it's coded in a hospital setting. But I thought the high unscheduled healthcare utilization was a really important point. So if you have a mom that's unexpectedly getting services, particularly in the emergency department, or being seen for things that might be concerning, infections or abscesses or trauma, maybe related to intimate partner violence or something like that, to have a really high concern for people who are seeking out that unscheduled healthcare utilization. So that's not necessarily returning for their postpartum visit, that's getting extra care because of some event that's happened in their life. That was incredibly predictive of overdose death. So just an important thing to keep in mind. Next slide, please. So overdose prevention, Narcan, naloxone, opioid overdose training and distribution. We know that naloxone is an opioid antagonist that rapidly reverses opiate overdose. We often, many doses are often required. This again continues to change over time. 5 or 10 years ago, it might be 1 or 2 doses of naloxone that could reverse someone. Now it's something more like 7, 8, or 9. So it's really common to need a lot of doses. There's a really low risk of trying naloxone if you're unsure of overdose. I'm always out teaching about that. Had a situation at one of my practices where a woman who was in her 50s overdosed and died, and there was actually naloxone in the home, but people did not recognize it as an opioid overdose. And so I think her family didn't necessarily know that she was in treatment. And I think, it's just important to have that on people's radar, to teach folks to have that on their radar, and to know there's a low risk, right? So if she's having a heart attack and you give her naloxone, not going to do anything, but it's not going to make the situation worse. It's our responsibility to carry it, to prescribe it often. And again, that might include to family members. It doesn't have to be for the person that has the opiate use disorder themselves, though it certainly can be and should be. Remind patients and families to always call 911. That is the one thing that people tend not to do. And I'll talk a little bit about the Good Samaritan law that's recently changed, but that is something that does not happen with any frequency. And no matter how much, I'll hear about a situation in the practice, an overdose requires 6 doses. And then I said, did you call 911? And no, it just doesn't happen. And it really does need to. So I pulled in here what places in which you can get naloxone through the naloxone distribution network. So this is off the options webpage if folks are interested, but you certainly can prescribe it as well. Some people hand it out in their practice. MaineCare, I believe, still only covers 1 kit per month, although I have had some conversations with Gordon and others about increasing that amount, because as I've already mentioned, 1 kit a month in a high risk situation is not going to be adequate. Next slide, please. Overdose prevention. So fentanyl test strips, some folks have probably heard of these. Some people are actually probably using them. They have changed dramatically from when they first came on the market. When I first became aware of them, I did a bunch of reading, and they were initially not particularly reliable. They just weren't really accurate. That has changed dramatically in that they are very accurate now. So that is an important point. They're pretty simple for people to use. They're inexpensive. They're like $1 each. And it's an evidence-based method of averting drug overdose. So people just dissolve a small amount of whatever the substance is in water and you dip the strip in. It is actually associated with positive changes in overdose risk behavior. So if patients if they're not expecting fentanyl and it tests positive for fentanyl, patients are more likely to use slower, use less, throw a batch away even, or use it with another person around. And I think that's a big piece too, that so much of the overdose deaths that we see are people using alone. And if this is a way to reduce that, that's a really important point. I think one of the biggest pros that I see about it right now is that these strips can detect for fentanyl when you might not expect it. So we are absolutely seeing, fentanyl-laced marijuana. It's fentanyl-laced stimulants is like everywhere. I mean, I feel like most stimulants have fentanyl, most fentanyl has stimulants. The other big piece is I've been reading about, college kids who think they're taking an Adderall and it's actually fentanyl that's pressed to look like an Adderall. Again, 10 years ago, the ones that, the drugs that were pressed to look like Adderall and other things looked terrible, right? They're the different color, they were flaking on the edges, they didn't look real. The new things might as well be Adderall. I mean, it's almost indistinguishable. So I think that's a really important place for fentanyl test strips. And as I said, they're much more accurate than they were. The cons, I would say, are that they're not really useful when testing your heroin, right? Because like all the heroin has fentanyl. So it's not, I think initially they were, pitched as a way to distinguish if your heroin, like your morphine and codeine, the natural from the poppy plant, had fentanyl in it. But now everything has fentanyl, so it's a little less useful in that regard. The one thing that worries me is that it detects some, though maybe not all, fentanyl analogs. So I'm seeing some really weird stuff in some of my drug screen results right now where people are coming up positive for heroin, like the old heroin, but not fentanyl. And I'm like, cannot be. So I don't know if there's a fentanyl analog that we're not picking up or what's happening. So that worries me that it might not pick up the newest fentanyl analog that's out there. And it can't gauge the amount of fentanyl. So it's a positive or a negative test. It doesn't tell you lots of fentanyl, little fentanyl, it just says yes or no. And then the other downside is it's considered drug paraphernalia in some locations. And so if you have paraphernalia laws around syringes and things like that, it can be considered drug paraphernalia. Next slide, please. So supervised consumption sites, this is a tough one. And this is what people always think when you talk about syringe exchanges. Whenever I talk about syringe exchanges, they're like, oh, you mean supervised consumption sites? I'm like, no, that's not what I mean. So supervised consumption sites are areas where folks can go and use substances in a supervised, safe environment. They have been I'll talk a little bit about the US, but in other countries, they've been shown to increase entry into treatment, reduce the amount and frequency of usage, enhances public safety, right? Because people are not using out in public and on the streets, reduces risky behaviors because those sites have things like clean syringes to be able to provide to folks. And you can successfully manage on-site overdoses, right? So they're reducing overdose deaths. So there have been like no overdose deaths at supervised consumption sites because that's entirely the point, that there's people there supervising. It is a considerable cost saver. So in terms of reduction of disease, overdose deaths, and I think the big one was the needing emergency services, right? So if people come across someone who's unresponsive on the street, they're calling EMS. This is a situation where if somebody nods off and is in the process of overdosing, you don't need to call EMS because you've got trained medical folks on site to provide naloxone. So supervised consumption is still not legal in Maine or the US, though some individual states and cities have approved the concept, which I found interesting. So it was last year, I believe, the Department of Justice versus the city of Philadelphia. Philadelphia actually lost due to the violation of a 1986 federal law that bans running a venue for illicit drug use. So there's all these sort of laws out there that it violates. But one did actually recently open within the last couple of months in New York City. And the Department of Justice actually came out saying, we may stop fighting this provided there's appropriate guardrails in place. So in other words, like, we may not take folks to court provided it's done in a responsible way. The Church of Safe Injection, which was founded by Jesse Harvey, the pictures in the upper right corner, who unfortunately died a couple years ago of a drug overdose. And Jesse was a wonderful person who really moved things forward in the state in many ways, opened Journey House and was just a great contributor to the understanding and respect. I think he was a true harm reductionist. I mean, he used to drive around and hand needles out of the back of his car. I mean, he was a true harm reductionist, a really good guy. So the team that's taken over for Jesse since his death has been advocating for one in Portland, Maine, I think to be continued as to whether or not we see it. But it is, you may hear about that. Next slide, please. So Maine's Good Samaritan Law. So what is that? That is a law that prevents a person from being arrested or prosecuted for a certain violation if the grounds for that arrest or prosecution result from the person experiencing a drug-related overdose or seeking assistance. So what it's designed to do is it protects individuals who in good faith seek medical assistance for a person experiencing a drug-related overdose or a person who's experiencing an overdose and needs medical assistance. So it protects, the challenge is that we've had one for quite a while. I think there's two challenges. One, I think there was a fair amount of law enforcement that were not aware that there was this rule. So I think sometimes people were arrested for things that maybe were covered under the Good Samaritan law. But then it was also sort of very tightly written. So it might be the situation that the person who actually administers the naloxone is protected, or the person who actually dials 911. But maybe the person who runs and gets a blanket to cover the person was not protected. Like, it had very narrow protections, and it had narrow protections on which charges you were also protected from. So if you had a warrant out for your arrest and other things, there were certain things that you could still get arrested for. So it was recently expanded, really to the credit of Courtney Allen and others who were involved in this. And it was just signed in like 2-3 weeks ago. I mean, this is like really hot off the presses, and others may know more about this, but it updated who was exempt. So it had a very loosely defined, helping could mean you just stayed there with them to wait for the EMS services. I mean, it really was very loosely defined, which was important, right? Because there was all this testimony. I don't know if any of you saw the testimony, but people who lost loved ones who, like, their loved ones started to overdose and people threw them out of the side of the car and just kind of drove off, or, didn't call 911 because they were afraid they were going to get in trouble and just let the person die. I mean, just really compelling testimony that was utterly heartbreaking. And it expands the number of offenses immune from prosecution. So there are certain things, if you have certain charges, outstanding murder charges, there's certain things that you would still be arrested for. But if it's a fairly low level charge, and you can't get arrested for, the paraphernalia, the drugs that are on the scene, whatever all else is there. So I think those are important distinctions. Next slide, please. So health and safety. So syringe services program, SSPs, needle exchanges, you'll hear those referred to in a bunch of different ways. Community-based programs that provide access to sterile needles and syringes, facilitate safe disposal of used syringes. And then I think potentially the most important thing is they provide and link to other important services. So that's, again, it's that connection point with the healthcare system where they're able to get what they need from a harm reduction perspective, but get them connected to other resources. So it could be substance use treatment, mental health services, medical services. Certainly the one that I worked with at Maine General, screened regularly for all kinds of infectious diseases, and some offer vaccinations, education about overdose prevention, safer injection, screening for sexually transmitted infections, certainly screening and care and referrals for abscesses and wound care that might come from substance use intravenously. And then naloxone distribution and education, I think, being a big one as well. I mean, I've talked to Shane before about some of the high risk, Shane being the person who runs the program at Maine General, and the risks of some folks who are actively using and needing 11 Narcan kits when they come in, because that's what they used, or that's what the folks that are around utilized in the last week. So it's pretty compelling. Next slide, please. So there's a really nice resource online, which I have the link at the very end of the slide, that this is just like a screenshot of the syringe service programs in Maine. So you can go onto this website and click and find one that's near to you. Some of them do mail syringes as well, but it's done by county. Next slide, please. Other harm reduction. So remember, MOUD is harm reduction, right? So I mean, it's giving someone a medication that's hopefully reducing their use and complications. That one's necessarily, reducing their use, but also the complications of their ongoing use. Especially helpful is low barrier access to integrated care, wraparound services. screening for worsening mental health disorders. So I just like, every time you make contact with particularly with a postpartum patient, I think, making sure, doing an EPDS and seeing where they are, and screening for ongoing mental health disorders is just really important, because I think the degree to which that contributes to risky behaviors that can cause an overdose is pretty clear. Peer support, another important, source of harm reduction. So it could be somebody who's really struggling, who needs that, a peer to help them, to have a safe person to talk to when they're struggling. So I put a couple links up here for various peer support groups, but I think really, really important resource for folks to be referred to. The whole movement to housing first, which is sort of non-abstinence housing. We have some of that here, which is just a housing first approach, views housing as sort of the foundation for life improvement. And it enables access to permanent housing without prerequisites. So there's a lot of housing that, sober house, right? So you have to not be using, or have to be in recovery for some certain amount of time, or they drug screen, things like that. I think the whole idea of housing first is that, people are not going to be able to get their recovery, in a place that they want it to be until they're housed, right? I mean, the whole idea that you send someone out with medication, they're probably not going to be able to keep it safe if they don't have a house. So that's the whole approach for housing first. Next slide, please. Oh, options. I was just like adding options to anything. I think just a really important website to know about. So it can connect you with your options liaison, which is, peer support in each county. They have their own. That can be an important source. You can get naloxone. You can learn more about Maine's Good Samaritan law. There's a lot of overdose information available there, as well as local resources. I think that's a really nice thing. So people can go in and plug in their town, plug in that they need behavioral health counseling, and it provides a list of resources there. I think it's a great option to refer patients to. Next slide, please. So some really interesting papers. As I said, the Maine syringe exchanges, the Maine SSPs, there's a link there. There's some interesting information from the US CDC syringe services programs. And then some really interesting papers out there about, drug overdose death risks. And I think the next slide has a few as well. But just if that's helpful for you to read, there's some interesting papers out there.